my name is Liz Ackley. I'm an associate editor for the Journal of Headache, and today I'm here with Dr. Jessica Ailani, who's the director of the Headache Center at Georgetown. Dr. Ailani is the first author of the paper entitled Cost per Treatment Responder Analysis of atogepant compared with rimegepant for the preventive treatment of episodic migraine, and is here to chat with us about that paper today. Good morning, Dr. Ailani. Thanks so much for chatting with me.
Thank you so much for having me on today.
Absolutely. I really enjoyed your paper, and I really appreciated that it looked at several different practical aspects of using these gepants. I would love for you to give me a little bit of an overview of what inspired you to do this study, and if you could tell us a little bit about your findings, that would be great.
Yeah, sure. So I have to say, I was really honored to work with this team. It wasn't my original idea, but two of our authors, Pranav Gandhi and Anjana Lala, who are from AbbVie and work on their healthcare economics team, have really engaged me to do a series of articles and papers that are focused on healthcare economics. I think as a clinician and a scientist, I've been interested in healthcare economics, not because I have a business degree, not because I went to business school, but because ever since I was a resident, I started to realize that every time we make a decision about a patient, we do impact overall cost. And if we could somehow manage making decisions appropriately, perhaps we could improve overall cost. I mean, I know that I'm one person in a giant system, and I do think sometimes costs are way above what we're actually doing. But in my mind, I always felt if I could do sensible, logical thinking when seeing patients and explaining some of the process to them as well, this would be really important. And so when opportunities came along where I could be involved in healthcare economic research, it was amazing to me to really delve into this idea of, can we actually look at the economics of migraine? Not only the impact the patient has when they're not treated, because we have done studies looking at the journey a migraine patient takes, which is, to me, one of the saddest things to look at, because we see our patients who really go through the healthcare system, spend a long time in the healthcare system not getting an appropriate diagnosis or treatment. We have plenty of articles about that. But what really happens now that we have targeted treatment, when a patient goes through that healthcare journey, turns out if they don't get targeted treatment, we know that they're going to stop treatment. And most of those patients don't go on to seek further care. So that's actually something that really frightened me when starting to do this kind of research, that I might be making cost decisions. I might be thinking, okay, let's try generic first and see how it goes, but that patient might not come back. And that's an opportunity lost for the patient, because we know that person is going to seek care in the emergency room. They're going to miss out on life. They're going to make other choices that are going to impact the healthcare system, but also them and their families and their children, and just the magnified amplitude. So this particular study was looking at two of our newer treatments. And it's interesting because we have so many of these new treatment options targeting CGRP, and we think they're about the same when it comes to efficacy, but are they really the same? Do they cost the same? This is something I think many of us don't know, dollar to dollar, how much do these treatments cost? And so this was a study designed to take a look in the best way possible, because it was not a placebo-controlled head-to-head study, which of course is the best kind of study to really look at this. And so it was taking a look at the pivotal trials for atogepant for episodic migraine and comparing the 60 milligram dose to the pivotal trials for rimegepant, 75 milligrams every other day for prevention of episodic migraine. We know atogepant is also approved for chronic migraine, but since rimegepant is only for episodic migraine, the choice was made to focus on episodic migraine. Because we have more study data for atogepant 60 milligrams, the choice was made, and there's a lot of decision making we had to do. So the choice was made to focus on 60 milligrams. A lot of math went into this. I won't get into that, but they chose to look at 50% response rate because that seemed to be similar in how the studies were designed. They took a look at week 1 to 9 and then also 3 month, because week 12, because in the studies, there were different endpoints for each of the studies. So they actually looked at both groups, and they tried to see how many patients did you need to treat on atogepant versus rimegepant to get that 50% response rate. And then based on the cost of the medication, what was the cost difference between the two? And I think when I got when all that math was done and the results came in, the first time we had our meeting to sit down and discuss the results, My colleague was behind me. I had my headphones off and I fell off my chair. It was pretty impactful because in clinical practice, there's a slight difference in how patients with episodic respond to a daily pill versus an every other day pill. So I kind of thought maybe we'll see a difference. Maybe atogepant patients would do a little bit better. I didn't really expect that. Basically what we found, you had to treat, the number needed to treat for rimegepant was about 13. The number needed to treat to see that greater than 50% response. The number needed to treat for atogepant was about 4.8 compared to placebo, but the cost difference was tremendous. It was about 15,000, 16,000 for atogepant and about 73,000 for rimegepant. And that's what made me fall down. So, it's a pretty big difference between how many patients you have to treat to see the improvement, but that cost differential, something that I think I pride myself on being pretty with it with cost. And I was embarrassed that I had no idea the cost differential. So,
wow, that's unbelievable. So it sounds like you weren't completely surprised by the results in the sense that, atogepant was a little bit more efficacious and more cost effective, but that difference in cost really blew you away.
it really did. It really did. And then I had to start thinking about what am I going to do in practice? What am I going to do in practice? How am I going to approach this when having conversations about patients when I really don't want to talk about money, especially if the patients there's a preference on their, when it comes to their insurance policy, they might have a preferred brand. But how do I really wrap my head around this? And then how do I start presenting these options to patients with this kind of cost differential? So, I've had these results a long time because we've presented this as abstracts for over the last year. So I'm really excited this is being published, as I can actually bring this to many more people because it has impacted how I practice. It makes me talk about the treatments differently. It does not mean I don't use rimegepant. It just means I've thought about my use a little differently, in that they're definitely patients it's a better treatment option for, but it might not be the first thing I go to for prevention, meaning someone who has 8 to 10 migraine days a month, and I want to put them on a traditional preventive treatment. It might not be what I lean into unless the insurance company is making that forced decision for me. I'm going to lean into atogepant. It has a lower number needed to treat. It's cost effective for the patient, for the healthcare system. I have the data behind that. But if I have a patient who's hesitant to be on prevention, I don't want to be on prevention, Dr. Ailani. I just want to take something when I need it. That's really still where I think rimegepant has that advantage, because they have the data that the more you use it, the better the patient does. I still think it's a great drug to trick the patient into using prevention. And I think it has a very strong standing there. So it's really just supported my difference in approach in how I come to the patient with treatment options, and really, really double down on the idea of it is patient-specific treatment, but we're taking cost into consideration.
Excellent. So admittedly, cost is not always top of mind for me when I'm in the clinic, and it's certainly not something that I spend a lot of time talking with my patients about. So how would you counsel me and other clinicians to think a little bit harder and smarter about cost when we're prescribing meds for our patients?
I definitely understand cost is not something we're taught to think about as clinicians at all. It's not part of our training. We're actually taught not to talk money, that patients don't like it, that they're going to think we're bringing that conversation in. I will tell you, though, the one thing that I've come to understand, every patient in that room is thinking about cost almost top of mind. They might tell you money's not a factor, but when you put it into monetary numbers, it's always a factor. And it's important to think about, because if you prescribe a medicine that's not formulary or not covered or is going to be a high cost, and this includes generic treatments, which unfortunately more and more are getting dropped off of insurance formulary plans or are becoming higher cost to patients because a generic might be a higher tier copay and a branded drug has a $0 copay. the patient, and we have data that supports this too, that patients with migraine often stop treatment because of cost. It's one of the top 5 factors. And the other thing a patient is doing that we don't often think about is if a medicine's only partially effective, that's very dependent on the patient, what that means. They will stop it if they think the cost is too high. And what is too high? That is very different from person to person and disease burden to disease burden. If a person with migraine, especially chronic migraine, has 5 comorbid disorders that they need medications for, and you're not talking about, is the cost burden too high for you? They might be stopping your treatments and not understanding, do I really need to be on this or not? So I think it's something we're not necessarily comfortable talking about, but it's really important we just edge into the conversation a little bit by starting with, are you comfortable with your copay prices? Is there anything you need to discuss? And at least trying to help set up a conversation with them, and maybe having someone in the office that you can feel more comfortable having them talk to if you don't feel comfortable having that conversation. But ignoring it is not doing your patient a service.
That's great advice and something that I'll definitely try to start doing. Dr. Ailani, are there any other research studies that you think would be really helpful to further explore this topic?
Yeah, so I think that if you're interested in thinking about how a treatment is working, definitely take a look at any of the studies out there that are looking at number needed to treat versus number needed to harm. This is a great way to do studies where you're looking at how many patients need to be treated before you cause a harmful event. It's a good way to compare different studies together. If you're also interested in cost analysis, there are plenty of studies coming out that are showing us that anti-CGRP treatments are actually cost effective to the whole healthcare system. And they're taking a look at how long patients are staying on treatments over 6 months, over a year, compared to traditional treatments. We're finding that actually patients seem to stay on treatments longer when they have to have the treatment in your office. That's, I think, not surprising. I think many of us who do treatments in the office, like injections, know those patients always make those appointments. But I think it's interesting because, again, when it comes to thinking in your mind about a person who maybe is not great with adherence and compliance, when you're offering them options, just bringing up, hey, I know sometimes it's hard for you to take a pill every day. Do you think it'd be easier if you come into our office for treatment? Again, just knowing your patients and that shared decision-making conversation and having that kind of healthcare utilization information really helps you bring that into that conversation in the room and help that patient make better choices for themselves.
Great. Well, this has been so eye-opening. Thank you so much for taking the time today to chat with me. And we're all looking forward to shifting our prescribing practice as a result of this paper. So thank you very much.
Thank you so much again for having me.
Take care.